First of all, let me thank Kiran and Binu for giving me this opportunity, the oft discussed dyslipidemia with no beginnings and ends. That is the topic of dyslipidemia. I think Dr. Pramod will come in a short time. He has some emergency in the hospital, so he is likely to join us. Before that, I think we will stop the topic. Well, what I plan to do is I have discussed some issues here, pointed out some issues, but when it is 40 minutes, I think we will conclude. Rest of the thing maybe we can discuss during the lunchtime or something like that. Now we will start with the simplest of problems, that is secondary prophylaxis. Because when you talk about primary prophylaxis, there are a lot of confusions. ESC says something, ACC, Lipid Academy of India goes even further down. So there is a lot of confusion. So we will start with secondary prophylaxis. Secondary prophylaxis, remember, is not only myocardial infarction or coronary artery disease. It includes stroke, it includes peripheral vascular disease, it even includes documented imaging evidence of atherosclerosis, like as Dr. Mugundan said, a high coronary artery calcium scoring, or maybe a carotid plaque demonstrated. So all of these are included in secondary prophylaxis. So let me ask Dr. Iqbal to tell us about, to enlighten us about how to treat as far as dyslipidemia is concerned in secondary prophylaxis.
Scandinavian simvastatin study, that is the FOREST study, which was published in 1994 onwards, the role of lipid management in the prevention of heart disease has definitely proven. The drug which prolonged the life longevity was considered to be one of the major drugs was a statin. From that onwards, from FOREST study onwards till after that miracle study, then a TNT study targeting new targets, and all have shown that different drugs like atorvastatin, simvastatin, everyone has shown to be beneficial in reducing the cholesterol, especially the LDL level, and preventing further episodes of heart disease. The statin, for primary prevention, secondary prevention, the drug used was initially it was statin, then later after the PROVE-IT study and most of the studies, the intensive statin therapy has shown to be much beneficial in stabilizing the plaque more than reducing the LDL level alone. So we use around 80 milligram atorvastatin or 40 milligram rosuvastatin at the episode itself. Like if a person developing chest pain and our lipid profile at that time onwards and starting statin at that episode itself, and recheck the cholesterol level after 4 weeks and see that whether it is controlled or not. So it takes maximum 4 weeks to take the maximum attained response. And if it is not controlled, we go for further additions. Addition of ezetimibe with the statin has shown that further reduction in the LDL level. Statin itself, maximum amount of tolerated taxane itself, statin itself shows around 40% reduction in the mortality. If you add the ezetimibe, it comes around 50%. Then other drugs like bempedoic acid, PCSK9 inhibitors, those were you added on the same drug with a maximum effect on LDL target. LDL target is, presently the target is around 50 milligram LDL. And in high risk group, it is even kept it as 30. The Lipid Association of India has kept the targets, recent targets in 2020 as LDL around 15, moderate risk, and very high, extreme high risk, it is 50 and even 30, and even dangerously very, very, very high risk like recurrent episode in spite of management, even the 10-20 is also acceptable. And unlike the diabetic drugs like reduction in sugar is not always associated with a severe increase in betterment of severe mortality, but always the reduction in LDL is associated with but reduction in the coronary events. So whatever the drug used, the reduction in LDL is always associated with the betterment. There is no single point whether the level of LDL can be said that this is an optimal. So it is linear.
Okay, so I think most most guidelines say at least if you have a secondary prophylaxis after an event, at least it should be 55. And as Dr. Iqbal said, some say 40, some say 35, because we now know after the PCSK9 inhibitor trials that even 25 does not do any harm. The only, and also there should be a 50% reduction. It is not these values alone. There should also be a 50% reduction. So suppose your baseline LDL is say 90, you should bring it down to 45, not 55. So both has to be satisfied. More than 50% reduction and an LDL of less than 55. The only question is, suppose the LDL baseline is 140. High intensity statin therapy will bring it down only to 70. So are you justified in giving combination therapy at the start? Suppose LDL is 140 coming with an MI. Will you start with the statin and ezetimibe? Are you justified in that?
So proved 22, TIMI 22 has shown that if you combine with ezetimibe and 40 milligram of statin is more effective than statin alone. So reduction will be 55%, up to 55% occurs with the combination. So initially, statin alone, if it's not controlled, then go for ezetimibe.
Okay, so the PROVE trial is, they are all chronic stable angina diseases. So in an acute coronary syndrome, there is no data comparing statin plus ezetimibe, but it stands to reason that you can possibly give a combination therapy like you give for hypertension or diabetes. Maybe dyslipidemia also, it is time to start combination therapy at the first lot itself. So let me now come to primary prophylaxis, which is more complicated because primary prophylaxis, you really do not know what all to look at before you start statin. We will start with primary prophylaxis without diabetes, because diabetes is a totally different entity. So I will ask Prasanna Kumar to tell us about primary prophylaxis in non-diabetes.
So it's a difficult topic. Without backup slides, it's difficult to extend, but even then I can give you some messages. The LDL reduction, whatever means by exercise, by diet restrictions, by you have a DASH diet, Mediterranean diet. When there is a reduction in LDL, there is a reduced events of ACVD, ACVD events. So we have what all things we have to look for. Now there are in Western countries you have a risk scores that is not available in India. So you have to first see the risks of the patients involved in your treating dyslipidemia. The one which we use in India, we can use WHO risk scores or the risk scores from the Britain, that is Q-risk 3 scores we can use. But usually when the patient comes for a treatment, when there is you to see the patient's patient's history-wise you get to see age, sex, patient's BMI, patient's physical examination, blood pressure, and then patient's lab parameters. When somebody has a cholesterol at the level of 190, you are supposed to treat whatever be the risk factors. Then the risk scores you can calculate there are something which is a recent score is a Prevent 2023 with the recent one. You can buy online. You can see the risk scores where you have to you have to give the input. You have to get the risk factors inputs. Whereby you can get stratification. You can buy low, intermediate, and high risk and very high risk groups. Accordingly, you have to treat. Suppose somebody has got a more than cholesterol of 190, then you are supposed to treat whatever be the risk source. And you have to check for the familial hypercholesterolemia as well. Suppose somebody has got a less than 5% of risk, then the statin is not indicated. Somebody who has got a very high risk score, so more than 20, then you are supposed to statin with a very high intensity statins. Somebody who has got a 7.5% to 20%, you have to start moderate intensity statins. Somebody with 5 to 7.5% risk scores, you have to see the other risk enhancers. If that is there, you have to start statins. Your aim is to reduce the level to less than 100. And of course, in low risk groups also, suppose you can see the 30 years risk stratifications. This 5, 7.5, all this done with the 10-year stratifications. And in India, we don't have any risk calculators, but in almost, suppose you take the risk stratifications in India, then Lipid Association of India, CSI and all, almost all, with a very low risk group, the medium risk, high risk, very high risk and extreme high risk. All this and of course, that extreme high risk and high risks are all ACVD patients that you're supposed to keep around 55, 40 like that. But even low risk groups, in India, they set a standard less than 100. Probably all of us, maybe it is more than 100 LDL. So there is no clear-cut guidelines, but we are all, in Indian setup, we have to keep less than 100. That's what it is.
Yeah, so the treatment of LDL or cholesterol in primary prophylaxis depends not only on the LDL level, but also on the patient's risk factors. The higher the risk, you have to have a lower level. Most guidelines say if you have no risk factors, you are a low risk person, 190 is the LDL cholesterol target, because 190 LDL in the vast majority is genetically determined. It is primary hypercholesterolemia, which in turn means that the number of years you are exposed to this LDL is from childhood, or the lipid years are very high. So that is why this above 190, everybody has to be treated. But as Prasanna Kumar said, being Indian, being South Asian itself is a risk factor. So maybe I personally would start treating above 160, give it a little down and bring it to about 160. And then of course there are high risk features like diabetes, which we will come to later, or other things like CRF, CKD for example, is now considered to be a very high risk factor. And when you are in doubt, you always have coronary artery calcium scoring to see whether to make a low risk patient into a high risk patient, or maybe looking at an ankle brachial index. And for a woman, maybe you should look at woman specific factors like gestational hypertension or gestational diabetes, things, and family history of course is also very important. Dr. Shauja, tell us about the more interesting thing, diabetes.
Yes, diabetes is a very prevalent disease, and we all know that it's considered as an ACS equivalent. So the majority of the audience here are physicians, and any patient coming to your OPD with a newly diagnosed diabetes, and if the age is more than 40 years, as per the ACC guidelines and ESC guidelines, it's a class 1A indication to start on statins. And we have to target for an LDL levels of 70 milligram percentage. So any diabetic patient coming to your OPD with age more than 40, AHA guidelines, ESC guidelines shows a class 1A indication to start on statins and target on an LDL level of 70 milligram percentage, which is not achieved. We have to add on acetamib and other agents. And one thing that I have observed in the practice is that physicians are a bit hesitant with the intensity of and the dose of the statins, because only if you start on moderate intensity statin means it is 20 milligram of atorvastatin or at least 10 milligram of rosuvastatin, then only we will have the plaque stabilization and pleiotropic effects of statins implemented in diabetic patients. And in addition to this, if the patient is having an ACS or acute coronary syndrome, as per the ESC guidelines, we have to be more stringent and make the LDL levels to about 55 milligram percentage, about to 55 milligram percentage. And younger age group, like 25 to 39 years of age, when to start statins, that as per the AHA guidelines is class 2A indication. But what I feel is that statin is the one thing which has got a really plaque stabilization effect. And if you examine most of the patients who are on moderate intensity statins, the presentation with ACS is relatively less than the patients who are on low intensity statins. So the message is any diabetic patients above the age of 40 years should be started on statins. That should be at least moderate intensity statins.
Yeah, that is, I think, an important point. It is not cardiology, ESC, ACC alone. Even Standards of Diabetes Care 2025 says all patients above the age of 40, diabetic, should be on statins. They don't talk about the baseline LDL level. They don't talk about other risk factors. All patients above the age of 40 years, diabetic, should be on moderate intensity statin. Then, of course, if they have target organ damage, albuminuria, for example, or if they have other risk factors, your level should still come down from maybe 70 or even in a very high risk individual to 55 also. What about less than 40? Diabetes less than 40.
It's a class 2A indication, but what I feel is that we have to be more intense with the statin management, because lot of late, if you examine most of the patients presented to us with ACS, the average age group is coming less and less. It is becoming 35 to 40. Patients coming with MI within the age group of 30 to 40 is also not very less. And one interesting point, what I just want to discuss is, as Sir was very passionate about Puneet Rajkumar in the morning, would you think if you have on 20 milligrams statin or moderate intensity statin, would he have had a plaque rupture? What do you see, sir?
It depends upon when he started the statin. After all these things, after the plaque is established, I don't know how much he would have benefited. One point with statin, yeah, with a high dose statin.
Yeah, the another thing, one more point is just I want to discuss is that we have used to get a lot of players while playing shuttle, football, and coming with younger age group with ACS present with MI. But when you do a coronary angiogram, what we see is more of thrombus. It's all plaque rupture what is happening when we play and all. It's plaque rupture is happening. So I think we have to be really aggressive with the intake of statins, even in younger energetic athletes. And some more emphasis should be there on starting statins early for better plaque stabilization.
Yeah, correct. Now, even less than 40 years, again, I am going to diabetic guidelines, not cardiology. What they say is even diabetic less than 40 years should be on statin if they have any one of the risk factors. And they say 1, 2, 3, 4 risk factors. One of them is LDL less than 100. I don't think there will be hardly any 40-year-old patient with diabetes and LDL less than 100, which means almost all patients, irrespective of their age, should be on statins. And as we have seen, they have hardly any side effects. So most of these patients should be on statins. The concept is that atherosclerosis comes when the LDL molecules comes into the subendothelial layer, and it is taken up by the monocytes and become the foam cells. Now LDL coming into the subendothelial layer can happen under two occasions. One, when the LDL concentration is very high, because of the concentration gradient, it can come into the subendothelial layer. Second is if the endothelium is porous or dysfunctional, when even small amount of LDL can come into the subendothelial layer. That is exactly what is happening in diabetes, where there is endothelial dysfunction, and in hypertension, smoking, all these things. So the point is that reduction in LDL depends not only on the value of LDL, but also on the risk factors. And diabetes obviously are one of the highest risk patients, because 70 to 80% of patients with diabetes finally end up in the cardiac ICU. So it is very important. The other problem with diabetes, as we all know, is the Indian type of dyslipidemia, where the LDL is not very high, maybe 100 or 110, but the triglyceride is 255 and the HDL is 25. And we know both these are very bad, high triglyceride and low HDL. The data is very, very confusing. Let me ask Dr. Pramod to clarify the issue.
This mixed dyslipidemia or hypertriglyceridemia is very common in the Indian population. And we know that triglyceride is a secondary cause for CAD. As such, more than 150 increases the risk for CAD, but it does not directly influence the atherogenic profile, but it is a precursor of atherogenic proteins like VLDL and IDL. So it is a secondary cause only. But when triglyceride is more than 500, it may lead to pancreatitis and other diseases. So in mixed dyslipidemia, in our population, if it is more than 150 with other risk factors, statins, better to control the triglyceride also. Many trials with the icosapent and the has shown the benefit with treating the triglyceride only. And coming to the HDL part, we all know that low HDL is a risk factor for CAD, but increasing in the HDL does not offer any benefit. So the previous trials with the drugs like niacin, after increasing the HDL, did not show any benefit in preventing the CAD. And more important is the function of the HDL. That is, the HDL function should be more targeted, and newer studies are now focusing on the improving the HDL function rather than improving the HDL count.
What about fibric acid derivatives? Because we have all atorvastatin F, rosuvastatin Fs in the market. What is your opinion on that? When do you give that?
If the patient with a high risk atherogenic profile, and if the triglyceride is more than 250, we can combine statins with fenofibrate. Otherwise, we can give only statins. That will also, rosuvastatin will also decrease the triglyceride. So if it is more than 250, it's better to start with fenofibrate.
Unfortunately, the problem is most of the fibric acid derivative trials have not been successful in reducing cardiovascular endpoints. They may prevent pancreatitis if it is above 500, but preventing cardiovascular disease with fibric acid derivatives is very, very questionable. Icosap and ethyl, of course,
Just shown
we
benefit.
have a very good drugs having some event rate. So triglyceride reduction, I think first of all we have to concentrate on lifestyle, and probably the most important thing is control of diabetes.
Diet.
Because any uncontrolled diabetes will have high triglycerides also. So instead of concentrating on triglyceride, maybe we should be concentrating on reducing, on controlling the blood sugar level. HDL is also same. No HDL reducing, increasing therapies has so far shown any cardiovascular endpoint benefits. Niacin has gone out of market. CETP inhibitors which increase HDL by 100%, 120%, but no effect on cardiovascular endpoint. So triglyceride and HDL are still treatment is still questionable, but we have at least some light at the end of the tunnel in icosap and ethyl. And now new small inhibiting RNAs and monoclonal antibodies are coming, acting at various levels of triglyceride metabolism. But we have to wait. They are all in phase 2, phase 3 trials only. But in LDL, we have a lot of new drugs, PCSK9 inhibitors, inclisiran, bempedoic acids. I will request Dr. Iqbal to tell us something about them.
Newer LDL reducing drugs like PCSK9, bempedoic acid, and inclisiran, they are available in the Indian market and is very effective also. And PCSK is in fact expressed in hepatocytes. It is related with the LDL receptor. So is monoclonal antibody inhibiting the PCSK receptor so type 9 that helps in the more expression of the LDL receptors and reduction in the serum LDL level. So is around 50% reduction is possible with PCSK alone, and if it is combined with the existing drugs like statin and ezetimibe and PCSK9, triple therapy, that goes around 70 to 80% reduction in the LDL level. And when it comes to the inclisiran is an synthetic mRNA derivative. It's also act on the PCSK9, and it's effective, but similar. Its effects are similar to PCSK9, but is comparatively lesser with the PCSK9. If we say PCSK9 is 50%, this is around 40% reduction. And bempedoic acid as a prodrug is when it's active, it's a bempedoyl coenzyme. It also blocks the biosynthesis of the cholesterol in the liver, and secondly, it reduces the LDL level. As effect is around 15 to 20% reduction in the LDL level. And it is useful when is avoid of the muscle toxicity, and when a person with statin has muscle symptoms, statin-induced muscle symptoms, it's better to change over to bempedoic acid.
Okay, so we have three new drugs there, of which the PCSK9 monoclonal antibodies and the small inhibiting RNA, inclisiran. Both of them produces tremendous reduction in LDL cholesterol when they combine with statin. As I said, patients had an LDL of 15% in the 4-year trials, and it showed benefit also. Bempedoic acid acts in a totally different pathway. In fact, it is in the same pathway as statins, as the HMG-CoA reductase synthetase. That's why the most guidelines say you give bempedoic acid when the patient is not tolerant to statin. But you can combine, there is no problem. You can combine statin and bempedoic acid also, but they act on the same pathway, that is the problem. So,
bempedoic acid increases the uric acid level. Yeah. And the major side effect is only increase in the uric acid and slight increase in the creatinine level. Otherwise, it's similar to the statin.
It is almost similar to statin in the pathway of action also. And it produces good reduction in good reduction in LDL, and we have the clear outcome study where there has been outcomes also have been reduced with bempedoic acid. Of course, they were in statin intolerant patients. Dr. Prasanna has already told us about the risk scoring systems, by the way, but I will ask him to explain a little more on these risk scoring systems.
That CVD is the leading cause of global mortality and morbidity. So in the Western countries, they have found out some kind of risk scores whereby they can estimate the risk of incident CVD in individuals without established CVD. So the risk scores actually they included, there is a data set characteristics, and then you have to risk factor inputs and the outcomes. These are the three things which they have included. For example, if you take the Prevent 2023 scores, they have taken the data from 1992 to 2017. That there's more than 6 million data are there in that group. So basically, data set characteristics are the number and the diversity of the population include the type of data, so for example, clinical or research, and the geographical area and years. And where with all these inputs, they add the risk factors, and then they found out the clinical outcomes. Especially that Prevent is the one which is prevalent, basically used in many, especially in Europe and USAs. In Europe and all, they already have a score 3 OP1, and China. In fact, China also has got a China PR 2016. This are the one which give you an idea what the supposed, because it has gone its own disadvantages and advantages. No single one is appropriate for all the patients. There are limited applications in individual cases as well. And moreover, if you have to promote the scoring, because the one which should be ease of use, applicability, accuracy, and then societal endorsement is also needed when you're supposed to use this one. When the other thing is that social drivers of health, like economic, political, social, and clinical care facilities. When it is this all things also there that impact the ICVD risk and clinical outcomes, especially the social STOH, what is called STOH, which can, if it is not that good, that can increase the ICVD mortality. That's a basic one. Which is
So risk scoring system, as President Omar said, there is no one universal risk scoring system which is applicable to all. Race may affect, and even among the same race, even Kerala's several people may be different. Now the concept after the Prevent trial is that what is determining is actually the SDOH, social determinants of health. Keralites are different from Americans, not because we have a racial difference, because our social and economic determinants are different from their social and economic determinants. So in a busy OPD, it is difficult to risk stratify. Unless you have a mobile app where you have to enter all, even then it is very difficult. But what I would say is that at least a rough subjective impression of what is the patient's risk it's sitting in front of you may help you to determine whether to give statin or not. It may be practically not possible to objectively assess the risk of all these patients, but at least some subjective risk stratification may be helpful in giving statins to these patients. And now let us go to another thing, lipoprotein little a, which we have been discussing for years together, but nothing has come out of it so far, because so far we had no drug which reduced lipoprotein little a. But now we have these PCSK9 inhibitors, whether they are monoclonal antibodies or small inhibiting RNAs, which have been found to significantly reduce lipoprotein little a. And so naturally all journals now have come up again with various seminars and discussions on lipoprotein little a. So Shaujad, where are we as far as lipoprotein little a?
Yes, as you know, lipoprotein little a is an LDL molecule with an apoprotein A attached to it. So the first question is whether we have to check lipoprotein little a for all patients. The answer is once in a lifetime, it is better to check the lipoprotein little a in all your patients, because although it's not a classical risk factor, some patients will be having a genetically elevated lipoprotein little a of more than 180 and all. If that is the case, we have to be more aggressive with the other risk factor modifications and treatments like better cholesterol control, better diabetes control and all, because these patients has got an increased tendency for cardiovascular events. How much is taken as the value of cutoff value for lipoprotein A is, that is also, there is a lot of controversy between a lot of trials, and mostly we take it as 50 milligram percentage. If it is more than that, whether to treat it or not is the another question. And as Sir said, our usual drugs like statins, acetamide, bempedoic acid doesn't have much effect on reduction of lipoprotein little a. Only niacin and PCSK2 inhibitors, 9 inhibitors, and inclisiran is found to be effective. But most of the studies shows there is no mortality benefit with the reduction of lipoprotein little a. Like unless for LDL reduction, there is umpteen number of studies which shows that there is mortality benefit. So in the current scenario, we don't worry much about lipoprotein little a. We just control the other risk factors and make your LDL levels are very well controlled, and lipoprotein little a is only very much highly elevated, and with a very strong family history only we have to go for this highly costly drugs like PCSK9 inhibitors and all. For the time being, we don't be very much worried about it, but once in a lifetime you have to check it to make sure that your lipoprotein little a is not highly elevated. And as we know, lifestyle modification doesn't have any role in lipoprotein little a reduction. Basically it is genetically acquired, so you have to make sure that it is not genetically very high and just forget about it.
So we are really very not sure whether lipoprotein little a is a risk factor or a risk marker. If it is a risk marker, there is no point in bringing it down. All you have to do is to control other risk factors more aggressively. Maybe that can also be included in the risk scoring systems. In a borderline patient where you don't know whether to give statin or not, if the lipoprotein little a is high, it may be justification for starting him on statin.
Yeah, basically we get a lot of patients, young patients, where there won't be not a non-smoker, normal cholesterol, normal diabetic profile. This type of patients is better to go for this checking of the homocysteine levels, lipoprotein little a and all, that will be worthful in those type of patients.
They made it as an extremely high risk group when there is a lipoprotein level.
South Asians are supposed to have high lipoprotein little a levels.
LPA level has an association with calcific aortostenosis.
Correct. Yeah.
They have very strong association.
True, they have a very strong association to aortic stenosis. And the other important problem, all social media are rich with the data on the side effects of statin. Dr. Pramod, please tell us, are they really side effects or they are only nocebo side effects?
We all know that statins are very safe drugs and it rarely causes side effects. The most common side effects reported by the patients are headache, nausea, vomiting, diarrhea, which goes by itself. The important association is the muscle-related side effects. It has been classified into 4 types. One is the myalgia. The second one is myositis. The second one is myopathy. Third one is rhabdomyolysis, and fourth one is myositis. So the myalgia, all patients will experience mild muscle pain, but with no CPK elevation. It will decrease by stopping the drug or reducing the dose. The second one is the myopathy. There will be some CPK elevation will be there. It can also be treated by holding the drug and changing the brand. Means you can convert that statin into rosuvastatin or reduce the dose once the symptoms get subsided. The dreaded complication is the rhabdomyolysis, where there will be high amount of CPK elevation. There will be urine myoglobin excretion, and the patient will have much symptom. Such patients should be advised to stop statins, and better not to give statins further. They can be switched to bempedoic acid, etc. once the patient gets settled. And the fourth one is the myositis. It is an inflammatory type. It is because of the antibodies producing against the HMG-CoA receptors. In such patients, with stopping the statins only does not lead to the symptom improvement. You should add anti-inflammatory drugs or immunosuppressant. And all these muscle symptoms are more common with those patients with autoimmune disorders, myositis, dermatomyositis or polymyositis. So we should rule out the autoimmune panel. And some drugs may cause interactions with the statins, like antibiotics, antiretroviral therapy, etc., may lead to the myalgia and myopathy symptoms. And the other rare side effects reported with statins are, some cases will show elevation in the liver enzymes, leading to hepatic failure, but that's very much rare. And other symptom is new onset diabetes, which we are almost, all the patients are more worried about. They frequently ask, do we get diabetes with on statins? But that's very rare as such than reported actually. In our practice also it is very seen less frequently.
So statins are fairly safe drugs. Even most of the muscle symptoms do not have raised CKMBs. They are more subjective symptoms. But all said and done, in primary prophylaxis, if the patient has some symptoms, he will stop it, unlike in a secondary prophylaxis. That is why in the clear outcome study, the definition for statin intolerance was patient is saying he is not able to take it. There is no CKMB, there is no LDL, nothing. So a statin intolerant patient is not going to take statin. Maybe that is the importance of bempedoic acid, because none of these things are there. Well, I have another 5 minutes remaining. I have some more points to discuss, but I think I will throw the discussion open to the audience so that any questions or any issues that you want to discuss can come up. We have another 5 minutes open to the audience, please. Any comments, questions? If non-HDL fragment. I will ask Pramod, who talked about HDL. Yeah, Pramod only. Do you want to tell us?
The current guidelines recommend that control of the non-HDL cholesterol. As we have already discussed, the HDL alone does not show any benefit. So non-HDL cholesterol, which includes LDL, VLDL, IDL, which are also atherogenic, these are recommended in the current guidelines.
Yeah, non-HDL cholesterol is a secondary target after the LDL target. It is plus 30, that is all. LDL target plus 30 will be non-HDL cholesterol. It contains all ApoB100 ingredients, including intermediate, all things. So it is definitely a good thing to look at. Anything else?
Whether we should. The importance of combination therapy, as all of you have suggested, has to be stressed. We have a recent data from LAI. In acute coronary syndrome, they used high-intensity rosuvastatin, bempedoic acid, and ezetimibe, and found, I mean, it's a very small study, but then even in ACS, people are trying to use 2 or 3 drugs. We have no qualms in using multiple drugs in diabetes and hypertension. Only in dyslipidemia, we have hesitancy. We should remove that.
Yes.
With the pregnancy is always, lipids are contraindicated actually. There is no doubt about it.
Pregnancy statins are contraindicated. If she is planning to become pregnant, we should wait till she completes her family and then put her on statins.
Bile acid sequestration are the only drug which can be used in pregnancy and lactation.
Yes, Sibu.
Regarding hypertriglyceridemia, and diabetes, the PPAR agonist, dual PPAR agonist, saraglitazar was previously there, and be still there, but not gained much momentum. So with this metabolic associated liver disease or steatotic hepatic disease, people are using these drugs. What is your comment on triglycerides and some hepatic problem, elevation of liver enzymes and all those things?
This saraglitazar was initially marketed as the best drug to reduce hypertriglyceridemia. Many have started using, but there was no evidence, means many trials showing the benefit in the CAD prevention, etc. No outcome trial was there. So it has gradually gone into oblivion, but some are still using it for diabetic control. It can be used, and it aids in the triglyceride reduction also.
Metabolic protection probably is there.
I think there is some study in MASLD they have.
PPAR.
I think there are some trials where they have used it for MASLD and found to be useful. But prevention of coronary artery disease, there is no data. After the fibric acid fiasco, now people are very hesitant about triglyceride. So you have to show a benefit of triglyceride reduction and cardiovascular event reduction, as happened with icosapentethine. So I think saraglitazar we will have to wait. little more before giving for, and to my knowledge, there is no trial going on in coronary artery disease. Yes, Jayakumar.
Regarding a point mentioned by Pramod, is this diabetes induced by statins so rare? Because my experience has been, though many patients with impaired fasting glucose, they become overtly diabetic after high dose statins. And many patients with very low HbA1c levels, when we repeat it after 6 months or 1 year, it becomes 6.2, 6.4 in the near diabetic range. So does this statin-induced diabetes reduce the effect of statins to some extent, or?
It does not, even though it produces, it is true that one of the real side effects of statin is it affects the dysglycemia, it affects glucose control. But overall the benefits are absolutely no doubt that the overall benefits far outweigh the small maybe increase in one drug that is required or something like that. So in fact, even pre-diabetics, it is an indication for statin. So I think there has to be no confusion about that. It does produce diabetes, no doubt about it.
Yes, as per the patients with impaired glucose tolerance, if you put on statins, they will definitely go into a diabetic range. But the overall benefits, if we consider, the cardiovascular benefits outweigh much more than the new diabetes induced. So it is we do not hesitate to start if the benefits are really there. So, but patients with very low HbA1c, the chances of going to diabetic is less. That's
is there any particular statin which is more prone to cause diabetes, or they are all same?
They say pitavastatin is less, but pitavastatin is a weak anti-statin also. So maybe rosuvastatin. It was first reported in the Jupiter trial, so naturally. The risk, yeah, correct.
Natural history of God-given diabetes versus statin-induced diabetes, we have no idea. We don't know. Is it same as the original diabetes?
If the patient has impaired glucose tolerance, it's better to start on atorvastatin than rosuvastatin.
And then treat diabetes also.
Yeah.
Okay, I think we have finished our time. So let me thank all the panelists for the good discussion and the reaction from the audience also. Thank you very much.